So at this time, I want to say, I can't say enough great things about this man, Dr. Jamil Aboulhosn. He started his career at UCLA and has continued his career all the way from then, from medical school until now. He trained in both adult cardiology and subsequently pediatric/congenital interventional cardiology, and actually trained with Perloff and Child, the legendary team that most of us actually learned adult congenital heart disease from. And then subsequently, he actually inherited that legendary program at UCLA. But more specifically, one of the amazing things that Jamil has done since then is he's become a leader and a pioneer in this burgeoning field of congenital heart interventions in the adult. And not only has he done some really amazing innovations and gotten his patients through some really amazing things, but he's also leading the way towards developing an evidence base for regulatory approval for congenital heart interventions in the adult, as well as to create an evidence base for standard of care in this field. And so, without further ado, Dr. Jamil Aboulhosn.
Thank you, Dr. Lin. Frankly, I don't think, well, prepare to be underwhelmed, I guess, is the best way I can put it. But it's a real honor to be here, and thank you for inviting me. So today I will speak to you about transcatheter interventions in congenital heart disease. I'll focus on adult congenital heart disease. And, you know, there are so many aspects of congenital heart disease interventions that we can speak about, from closing holes to opening holes to replacing valves, that I wanted to focus specifically on the pulmonic valve, which is very important for us in ACHD and, frankly, not usually on the radar of adult cardiology. So hopefully I can impart some new knowledge and also tell you where we are with transcatheter valve replacement in this particular space. So I do have some pertinent disclosures in that I am a proctor for Edwards Life Sciences, the makers of the Sapien valves, and also have research grant funding from them and from Medtronic, who make the Melody valve. But I will try to be as balanced as possible. I also have this disclosure being on the exam writing committee for the board exam, but I will not, and I have to actually show this slide every time I give any talk anywhere, that I will not give you any exam questions in this presentation. Wink, wink. No, I'm just kidding. All right, historical perspective. So let's start there. Congenital heart disease is the most common congenital abnormality, and it affects about 0.8% of all live births. And actually, it depends on what you call congenital heart disease, because if you're in Italy and you include any kind of congenital aortic valve abnormality, even mild forms of bicuspid aortic abnormalities, then the number rises to almost 3%. Why in Italy? Because they screen with echocardiography all children, young adults participating in sports. So the more you look, frankly, the more you're going to find. If you include atrial level communications like PFOs, then the number is going to go up to 25% of all human beings. We don't add those. But if you look at real congenital heart disease, then we're talking about close to 1% of all live births. If you go back to the early part of the 20th century until the 1950s, complex forms of congenital heart disease, especially cyanotic congenital heart disease, were in a large part not compatible with long-term survival into adulthood. And about 90% of patients died before they reached adulthood. That has changed dramatically. It's actually been one of the great success stories in medicine, is the change in the long-term outcome of complex congenital heart disease, especially the blue babies. And now survival has become the norm for most types of congenital heart disease. There are certain forms of congenital heart disease that are just not compatible with life. And the one that really jumps to mind is pulmonary vein atresia. So if you do not develop pulmonary veins, there's no operation that can be done to save that baby. But pretty much everything else can be palliated or surgically corrected. So the population of adults with congenital heart disease has therefore grown in the United States by about 5% per year, and that's true for the developed world. This is not true for much of the rest of the world. Why? Because early childhood screening is not done uniformly, and frankly, interventions may not be available to allow this kind of survival into adulthood. But we are seeing slowly but surely these changes occur pretty much everywhere. But now in the United States, the numbers are increasing about 5% per year, which is why I have a job and Huie has a job and now has a new partner, and frankly, why institutions like ours and yours should be investing in this field, because it is a growth industry. Much of the credit for the success of the field really goes back to the early surgical pioneers like Blaylock, Crawford, Gross, among others, starting in the 1940s, late 1930s and 1940s. Those early operations before the advent of cardiopulmonary bypass were by necessity extracardiac operations. Why? You couldn't stop the heart, you could not bypass the heart at that time. So you could operate on the vascular tree like the aorta, for example. If you had a coarctation of the aorta, and surgeon could go in through a lateral thoracotomy, didn't have to arrest the heart, could clamp the aorta proximal to the area of coarctation, distal to the area of coarctation, cut out that segment, and then do an end-to-end repair. So that was doable. Ligating a patent ductus arteriosus. Again, you don't need to go on cardiopulmonary bypass for that. So that wasn't a problem. But it wasn't really until the 1950s, with advances in cardiopulmonary bypass, that surgeons were able to now operate inside the heart, to close ASDs, to close VSDs, and eventually to do valve repairs, valve replacements. And that really brought cardiac surgery to the forefront of medicine. And the golden age of cardiac surgery was really in the 1960s, 1950s and 1960s. Those early blue baby operations, the first transplants, etc. But by the turn of this century, and it sounds crazy to say, it's like, think about it and you go, by the turn of the 21st century, we're already almost 20 years into the 21st century, cardiac surgery for congenital heart disease had become a refined art. And we should remember that cardiac surgery actually started with congenital heart disease, right? It wasn't coronary bypass grafting that was done. It wasn't aortic valve replacements for people with calcific AS. It wasn't mitral valve repair. It was operating on blue babies and operating on patients with congenital heart disease. Same for transcatheter interventions, frankly. Didn't start with coronary interventions. It started with congenital interventions as early as the 1950s. So the last 2 decades have witnessed just an absolute explosion of percutaneous transcatheter interventions. And in my mind, this has been catalyzed by several factors. Number one, advances in non-invasive imaging techniques. And really, echocardiography is front and center here. This is the workhorse for structural cardiology, for all of cardiology. And, I have the somewhat unique position now of being able to go back into the records of our patients from the 1970s when Joe Perloff was seeing them in the early days of the congenital heart disease clinic at UCLA. And, not that many of those patients had echoes back then, very early forms of echo. And so the diagnosis was being made based on physical exam, EKG, chest x-ray. And it's really nice to kind of look back and see, how accurate were those methods compared to echocardiography and now MRI and CT, cross-sectional imaging modalities. And cross-sectional imaging modalities like MRI and CT are an added bonus, right? Because now you're able to actually look at three-dimensional structures that are quite complex. And I will tell you that, those early pioneers were pretty good, but they're not as good as CT and MRI. Or echo for that matter. So it allows us to make more accurate diagnoses, and so therefore when we're taking patients to the cath lab to do procedures, we're not taking them to find out what's going on. We know what's going on. It's like satellite imaging before a ground invasion, right? No one at this point, would invade a place, unless you know that there are weapons of mass destruction based on satellite imaging. All right, and I'll go on. Advances in catheter, device, and wire designs have allowed physicians to easily engage unusually located structures and tortuous vessels and to deploy various devices. New materials, and really the one that's important for us, and it's not that new anymore, it's actually from the 1970s, is nitinol, which is a nickel and titanium alloy, almost 50-50. Nickel and titanium. If you combine these metals together, then you get this new material that has multiple properties that are great. Super elasticity, and it is very resistant to bacteria sticking to it, very resistant to thromboses, et cetera. We would not have ASD closure devices, for example, without nitinol. All the Amplatzer line of products for ASD, PFO closure, VSD closure, et cetera, involve nitinol. So that's been important as well in moving us forward. And then advances in imaging within the cath lab. So not just before we get into the cath lab, but once we're in the cath lab. Digital fluoroscopy, that's great. Intracardiac imaging, transesophageal echo in the cath lab. You know, no one is doing an ASD closure these days just using fluoroscopy, right? You're using ICE, you're using TEE. Some places they'll use even transthoracic echo, but you're getting added imaging guidance for your interventions within the cath lab. And you guys are also uniquely positioned here to appreciate the importance of digital registration, rotational angiography, taking CTs and MRIs that were done before, and then actually overlaying those images onto the fluoroscopy screen to allow us to see better in the cath lab and also to assess the results of our interventions in the cath lab more accurately. And then lastly, hybrid procedures, bringing the talents of our surgical colleagues and of the interventional colleagues together and realizing that, you know, the two are complementary and can be very symbiotic. You know, why try to replace a valve in a very complex transvascular way if you have occluded femorals and an occluded right IJ, and you have to go in through the left IJ, and you may not be able to do it when you have a surgeon that can do a subxiphoid incision, give you direct access, and then you pop in right away. How you doing? Wow, I'm seeing some old faces here. All right. Patients with RVOT. Yeah, not as young as they used to be. So I'm going to focus on patients with right ventricular outflow tract abnormalities, which are about 22% of all congenital heart disease patients. And we're talking about almost 9,000 births in the US per year. And if you look at this chart here, you'll see that the majority of these patients have tetralogy of Fallot. Now, tetralogy of Fallot consists of, if you remember this from medical school, you know, four major aspects, right? So you've got a hole in the heart, a big VSD, you have an overriding aorta, you have some form of obstruction to right ventricular outflow to the pulmonary arteries. And that can be at multiple levels or at one level. And you have right ventricular hypertrophy by necessity. So these patients with tetralogy of Fallot basically come in two major types. You have tetralogy patients who have a pulmonary valve and have stenosis of that valve, and you have others who have complete atresia of the pulmonary valve, where it has not formed. Those that have atresia of the pulmonary valve, when they do get an operation, require some kind of conduit to be placed because there's no connection. Pretend, you know, there's no bridge between the right ventricle and the pulmonary artery into which you can easily put a valve, so you have to create a conduit. And usually in children, they're using homografts to do that. So that's in patients with pulmonary atresia. The other patients who get these kinds of conduit types of operations are those with less common diseases like truncus arteriosus or those with transposition of the great arteries that have double outlet right ventricles. And then others, we include patients who've undergone things like the Ross operation, which is you know, an interesting operation in that what you're doing is you're operating on patients who have severe aortic stenosis, and you're replacing the aortic valve with the pulmonary valve as a pulmonary autograft, and then you're putting in a homograft in the RV to PA position. So you're taking a single valve problem and really turning it into two valve problems, and inevitably 15, 20 years later, the patient is going to require replacement of the pulmonic valve, and occasionally the aortic valve will fail as well. So all of these are the black boxes, are patients who end up with some form of conduit or bioprostheses, and that forms about 23% of all RVOT patients. And that population right now is the population in whom we can replace these valves, transcatheter pulmonary valve replacements, with FDA-approved devices. The other 77%, and these are the patients who have tetralogy of Fallot, who are born with pulmonary stenosis but not atresia, those patients do not have conduits for the most part and had repair with either a valvotomy or a valvectomy or some sort of transannular patch repair. But we say those patients have native right ventricular outflow tracts. Now, that's a little bit of a misnomer because it's not always completely native. There may be a Gore-Tex or pericardial patch on top of it, but be that as it may, you do not have some sort of cylindrical circular landing zone into which you can put a balloon expandable valve in that population. So they're a lot more heterogeneous and more difficult to go after with transcatheter valves, higher complication rates, et cetera. So in this population of dysfunctional conduits, and this is an example of a bioprosthesis that is dysfunctional, and you have various kinds here. So this is a bioprosthetic valve here. Here's a synthetic conduit. These are homografts, a pulmonic and an aortic homograft, more synthetic conduits. Great, great, great. The problem with these is they all have a finite lifespan and they need replacement. Typically in the adult, we're talking about a 15-year lifespan. In a child, lifespan is much shorter. You put one of these in a child, it'll need to be replaced, and especially a young child, less than 5 years of age, it typically needs to be replaced within 5 years. So it'll last longer if you're an adult. Why? Your immune system is not as vigorous as a young child's is. This is the treatment regimen for RVOT dysfunction, and this is kind of my vision for how I think things will go and the way things are going now. So inevitably, you're going to need surgery early on in life for something like tetralogy of Fallot. We cannot take a baby to the cath lab and try to close the VSD, create an RV to PA conduit. It's just, they will need early surgical intervention. I don't see a way around that. And we'll probably need a replacement of a conduit within the first few years. So I would say the first 5 years of life belong to our surgical colleagues. But thereafter, for the next, I spelled adult with 2 T's there, sorry about that. For the next 70 years, the hope is that future pulmonary valve replacements can be done using transcatheter techniques. These are the 3 valve systems that are available now in the United States. 2 of them are FDA approved and 1 of them is not. The SAPIEN XT is FDA approved. The Melody valve is FDA approved. The SAPIEN S3 as of yet is not FDA approved. But we just completed the Compassion S3 trial, and the hope is that this SAPIEN S3 will be approved in short order. And they all have different characteristics that either favor them or go against them. The Melody valve is a fantastic valve, but it has some major issues. And one of the issues with the Melody valve is that it's a little bit too small for especially native RVOTs. It goes up to a maximum outer diameter of about 24 millimeters if you have it on a 22 millimeter balloon. If you try to get it up to a larger diameter than that, then it tends to leak. The other issues with the Melody valve is it tends to have very thin, pliable leaflets. The Melody valve is not actually an engineered valve. It's a valve that is a bovine jugular venous cuff taken from these large cows in the Dakotas and in Minnesota. So this is made in America, this valve. Good beef as well comes out of those cows, I'm assuming. But the big picture with the Melody valve is that the size is a little bit too small, and it is not a great valve in high pressure circulations. The SAPIEN valves are engineered bovine pericardial valves, but they are a little bit different in that they go up to a much larger diameter. So the S3, for example, goes up to a 29 millimeter diameter, but can be taken up to almost 31 millimeters outer diameter. So it allows you to intervene on much larger native right ventricular outflow tracts and place the valve in much larger bioprostheses. The SAPIEN XT is somewhere in between the two, and frankly, for those of us that work at adult hospitals where the SAPIEN S3 is available, I think most people have moved away from using the SAPIEN XT. Unfortunately, at many children's hospitals, they cannot get the S3, so they have to use the XT. But it's the second generation SAPIEN valve. It doesn't have the cuff that the S3 has around it here, and it doesn't go up to as large of a diameter, and the delivery system is a lot more cumbersome. So this is the Melody valve, and you can tell here that the leaflets are extremely thin, right? This is a bovine jugular vein. There's two types of Melody valves. There's Melody Junior and Melody Senior. That's not what they call them. That's what I call them. But Melody Junior is a maximum diameter of 20 millimeters. Melody Senior is a maximum diameter of 22 millimeters. They used to not have Melody Junior. They were throwing away all of these smaller cuffs. And we said, well, hold on a second. There are younger, smaller patients in whom we could potentially use these, so please don't throw them away, and then they didn't. One of the other limitations of the Melody valve is the stent platform, which is a platinum iridium frame, and the frame, unfortunately, is very prone to fracture. So if you put the Melody valve in by itself in a native RVOT or in a conduit, think about how hostile that environment is for any kind of stent. It makes sense that these things would fracture because it's between the sternum and the aorta, and it's constantly being compressed, 60, 80 beats a minute between the sternum and the aorta. If I gave you a paper clip and I had you take the paper clip and sort of unwind it so it's straight, and I had you do this for a couple of seconds, what's going to happen? It's going to fracture, right? Now, if I gave you 3 paper clips and I said, okay, try to do that with 3 paper clips, you wouldn't be able to do it. So the idea here with this Melody valve is that if you're going to implant it in native right ventricular outflow tracts or in conduits, you should pre-stent those conduits with other stents and then put the Melody valve in. So it's a little bit more cumbersome to do that than to just go ahead and put in the SAPIEN valve, for example. The SAPIEN valve is not prone to fracture in the same way. Here's an example of a Melody valve in a young man with a severely narrowed RV to PA conduit. So this was a homograph, heavily calcified here. You see some calcium there, pushing it in. This is an AP view. Here's your right ventricle. Here's your pulmonary artery. You can tell the severe narrowing there. So severe regurgitation and stenosis in this young man. So you put in the first stent, and great, but look at that. See how it's kinked right there? And this is at very high atmospheres. You're going 18 atmospheres, and you still can't open it up. So then you end up putting in another, I think I did another 4 stents in this young man. And what you're doing here is stent after stent after stent, and you're trying to basically build a circular landing zone so that this valve can work properly and so that you're not left with severe stenosis. And eventually you put in the Melody valve, and it looks pretty good. And then this is what it looks like on FOSS. So a pretty good result. Yes, it took a lot of work, many stents, a lot of fluoroscopy, but you kind of have to do that in these cases. Otherwise, you're not going to come out with a good result. And this man had this valve put in over 9 years ago and is still doing well, and the valve is still doing well. So good success story. Yesterday at dinner, we were talking a little bit about overlay, CT and MRI overlay, and 3D rotational angiography and its utility in the cath lab. I've got to be honest with you, I think we're still sort of in the early stages of this. It's kind of a like 1982 Pac-Man right now. One day it will be, Battlefield 2, but not quite yet. Okay, so there are some limitations. Why? And you can see what the limitations are. Okay, the image doesn't move. The heart is a dynamic organ, right? This thing just kind of sits there like a blob. Fine, but it's not moving very much. Now, you can try to respiratory gate it so that it moves with respirations, and that's fine, but you're still not getting the beat-to-beat variation that you would with a normal heart. It's just a matter of time before that gets fixed, and we have the processing power to be able to do that. But this is an example of a Melody valve being replaced in a gentleman with a failing bioprosthesis who had renal insufficiency. His creatinine was 2. We didn't want to give him much contrast, so we decided to do the entire case essentially with overlay. Did we absolutely need it? No. Why? Because you know where your landing zone is. Your valve is right there. But it shows you how we can actually do this in the cath lab and ghost the image in and out as needed. Bioprosthetic valve fracture. This is becoming increasingly important for us, especially in those who have undersized bioprostheses. So someone gets say a 23 millimeter bioprosthetic valve when they are 8 years of age. And now they are 30 years of age, and this thing has an internal diameter, say, of 19 millimeters. Now, are you going to go and say this is a 6-foot young man? Are you going to go in and put in a transcatheter valve and create more patient prosthesis mismatch here? Or are you going to try to open up that original bioprosthesis? And the idea here is that we can take these valves and we can do this. You go up with a really high pressure balloon and then pop, you fracture it. So you're fracturing the ring of the valve and you're getting a few extra millimeters of internal diameter there. And in my mind, this makes a lot of sense to do on a regular basis. And I've started now doing it pretty much in most of the bioprostheses I go after, in the pulmonic position and in the tricuspid position. So essentially, trying to create the largest landing zone possible. What are the clinical and hemodynamic outcomes of the Melody valve over time? Well, this is supposed to be a 7-year study, but in reality, if you look at these numbers, this is more like a 4 to 5 year study. Not bad, but there is a significant reintervention rate that's needed. The death rate is quite low. The explantation rate is close to 10%. If you look at this here, most of these patients didn't need redo transcatheter pulmonary valve replacement, but may have needed other things done as well, like addressing the branch pulmonary arteries. These people can have branch PA stenoses as well. Now let's move on to the SAPIEN valve and talk about that a little bit. We had the Compassion trial, was recently published. Basically, the outcomes are very good with this valve as well. High technical success rate, no frame fractures. There is a small risk of endocarditis with this valve as well, although those of us that use a lot of these valves, I think would say that it looks like the SAPIEN valve endocarditis rate is probably going to be lower than the Melody valve endocarditis rate. But we'll have to wait and see as we have more experience with the SAPIEN valve. Adverse events, again, not very high numbers there. And then if we look at our own experience here, this is from 2010 to 2016, and it kind of gives you an idea of the way this field is going. You know, if you would have taken these numbers from, say, 2000 to 2010, the vast majority would have been surgical. 95% would have been surgical. But now, over the last 6 years, you see that the majority are actually transcatheter, not surgical valve replacements. And if you look at the differences between the patients that had surgery versus transcatheter valve replacement, we were doing more surgeries in those with tetralogy of Fallot as a primary diagnosis. And if we go back to that chart I showed you at the beginning, those are the patients with native RVOTs. The majority of those have big native RVOTs. And when we started using the Melody valve back in 2010, you know, we couldn't actually put that valve into those big native RVOTs because it's too small. So we had to send those patients to surgery versus patients who had transcatheter valve replacements tended to have either pulmonary atresia or some other RVOT abnormality that necessitated the placement of a conduit or a bioprosthetic valve. Number of sternotomies, the patients who went on and had transcatheter valves had more sternotomies. History of prior endocarditis. This shocked me. I did not know this until we looked back at our data. But it turns out that we are selecting out a worse substrate for endocarditis in the transcatheter valve population in that almost 5%, actually a little more than 5% of our patients that had transcatheter valves put in had a prior history of endocarditis. And so it's not shocking that these patients are more likely to then develop endocarditis later because, you know, you're not taking out that valve or homograft that had originally been infected and treated. And we know from our orthopedic and ID colleagues from osteomyelitis that if you treat a patient with a bone infection, for example, and by all measures it looks like it's cleared, they may get a recurrence 20, 30 years later, and it's the same organism, the same Staph aureus, the same strep. So we don't think that these bacteria go away completely. They probably lay dormant, small numbers within these heavily calcified conduits. And then what do? We go in there with our high-pressure balloons, and we mash the calcium, and then we put in this Petri dish, right, this bovine pericardial valve in that location, and then we're shocked that it gets infected. So I think there's reasons why this happens. And then much more likely in our population to have had a conduit if you had a transcatheter valve. Cardiopulmonary bypass time is obviously going to be very different because we're not using cardiopulmonary bypass for transcatheter valves. The length of hospital stay, quite a bit shorter. It was 1.6 days back then, but I can tell you since 2016 to now, we're getting people out within less than 24 hours, almost always within less than 24 hours. And we could probably send people home the same day. Even if we're using 22 French sheaths in the femoral venous location, because we can double pre-close those veins. And so if push came to shove from a cost standpoint and we needed to get people out, this is a procedure where you should be able to get people out the same day and save money on that. Predictors of infective endocarditis. So a history of endocarditis, very powerful predictor. Presence of an RV to PA conduit makes sense, right? Those are the ones that are narrowed, heavily calcified. Severe pulmonary stenosis, high velocity turbulent flow through a narrowed conduit, right? Or bioprosthetic valve. All of these increase the risk of endocarditis. And this just shows the same thing, where you start out with a valve that may not be completely free of stenosis, so you get turbulent flow through that valve. If you stop the aspirin for any reason, then there's a likelihood that thrombi will form, and then those thrombi can get infected, and so on and so forth. So it's really key for us that our patients actually continue on at least one antiplatelet agent long term. I never stop antiplatelet agents in these patients. And there is some debate as to the benefits of full anticoagulation in this population. We know that the way TAVR valves in the aortic world fail early is through thrombosis, leaflet thrombosis. And we know that that risk is much lower if you anticoagulate the patients. And so the question is, would it be better for us to anticoagulate these patients, yes or no? And at this point, I'm not generally anticoagulating all my pulmonic valve patients, but I'm putting them on antiplatelet therapy. But I am anticoagulating all my tricuspid valve patients, the transcatheter tricuspid valve patients. I feel that those have a much higher risk of valve thrombosis than other positions, and that's been my experience at least. So this is our transcatheter endocarditis experience, basically from 2010 to September 2018. So we had a total of 306 valves that were implanted in 295 patients. 268 of these, and these are just in congenital patients in the pulmonic and tricuspid positions. But 268 of these were pulmonary valves in 261 patients. We had 12 patients that developed endocarditis, 4.5% overall rate. 5 patients actually had recurrent endocarditis, which is quite concerning because it wasn't always the same organism either. Sometimes different organisms. So we had a total of 16 episodes in 12 patients, which is about 6% of all PVR cases. 2 had to have surgical valve replacement. 2 underwent repeat transcatheter valve replacement after a full course of IV antibiotics. This is a CART analysis. This is a classification and regression tree analysis. I find this extremely useful in clinical decision-making, trying to identify, who's at the highest risk, who's at the lowest risk. And it's important to identify the highest risk, but also the lowest risk patients, to know in whom we can safely use the Melody valve and in whom, we may want to go to surgery instead of trying to be heroes in the cath lab. So if you start with the first question is my patient immunocompromised, yes or no? And what is immunocompromised? Well, for us, in this series, immunocompromised is anyone with DeGeorge, 22q11 deletion, okay, which occurs quite commonly in tetralogy of Fallot patients. We know they have a T-cell abnormality. People with HIV or AIDS, people on chronic steroids, people with immune globulin deficiencies. But somewhere in the chart, it had to state that the patient was immunocompromised. So if that's the first question you ask yourself, and the answer is yes, at least at UCLA, the risk of endocarditis of a transcatheter pulmonary valve is now 21%. So 1 in 5 is going to get infected. Then if the next question you ask is, okay, I went into the cath lab and I just replaced this pulmonic valve, and I'm now leaving the cath lab with an RV to PA peak-to-peak gradient. This isn't by echo, this is by direct pressure measurement in the RV and the PA. If the gradient is higher than 15 millimeters mercury, 15 or higher actually, then the risk goes up to 43%. Very high, right? So what does this tell me? A, maybe you shouldn't be doing this in people who are immunocompromised. And B, if you are going to do it in people who are immunocompromised, you better go into that cath lab and get that conduit as large as possible, fracture that valve, do whatever you can to get that gradient way down. Like that first case that I showed you where I put in 5 stents and then the Melody valve. Okay, that was before I knew this, but now I'm really happy I did it, and that guy doesn't have endocarditis because he left the cath lab with a lower gradient. Now let's go to the other side of this classification tree. If the question is, are you immunocompromised, the answer is no. Now all of a sudden the risk is down to 5%. If you ask the second question is, do you have a history of infective endocarditis? And if the answer is no, then you're down to 4%. And then now you're in the cath lab. You get a good result. Huie goes to town and puts in a huge sapien valve, and there's no residual pulmonic stenosis. Then the risk is down to 2%. So 2% versus 43%. So, you know, and this is now kind of driving my practice. I'm much more aggressive in the cath lab about relieving pulmonic stenosis, and I'm risking conduit rupture a little bit more. So endocarditis after transcatheter pulmonary valve replacement, this is a recent publication in JACC by Doff McElhaney and his group. It's actually a multi-center publication. Again, looking at rates here, 11% over 5 years. And that's unacceptably high. I mean, honestly, I'm shocked our surgical colleagues haven't tried to get us out of the game here, given these high rates. And I think I know why they haven't, because these are really difficult operations, very bloody operations, especially someone who's having a 4th time redo, 5th time redo, going in and hacking out a calcified conduit. I think they'd rather just have us take care of it. So let's move on now from pulmonary stenosis to regurgitation. Pulmonary regurgitation. Usually it occurs after surgical treatment of pulmonary stenosis or tetralogy of Fallot. Well tolerated for about 2 decades, but then you start running into trouble. And when you run into trouble with right-sided lesions like pulmonary regurgitation or tricuspid regurgitation, frankly, in my mind, you're in a lot more trouble because you then have a multi-system problem now. You've got progressive heart failure, you've got renal failure, you've got liver failure, which is why tricuspid valve surgery, for example, is so high risk, you know, almost a 10% risk of mortality with tricuspid valve surgery. So don't ignore the right side of the heart and don't ignore the pulmonic valve. When I was in my general cardiology training, I was told, and this is back in the 90s, that, you know, pulmonary regurgitation isn't of much consequence. Really, nobody worries about it too much. But I will tell you, for us, it's a huge problem with eventual multi-organ failure. If you're doing a cath and you put up your catheter into the pulmonary artery and the pressure tracings look exactly like the RV pressure tracings or very similar, then you have pulmonary regurgitation. Okay, so just for those of you doing caths, if you're doing that, you go, oh my God, look at that. That PA diastolic pressure is exactly the same as the RV diastolic pressure. You might have pulmonary regurgitation. If you're looking at your catheter and it's in the branch PA and it's doing this, you might have pulmonary regurgitation. If you do an injection in the branch PA and you see the contrast come all the way back to the RV, you pretty much have severe pulmonary regurgitation. This is an MRI, this is an MRI here of a patient with a transannular patch. And this, I like to show this because it just shows why transcatheter valve replacement in this population is so difficult. where are you going to put the valve? You know, there's no calcium here. So this landing zone is going to be extremely pliable. This transannular patch here is gigantic. So nowhere to put the valve here gets a lot more challenging. So what's the problem? Big RVOTs. You need big valves. You need big delivery systems. You know, for those of you that do coronary work, you guys are like riding Vespas, okay? This is like, this is driving an 18-wheeler truck through the heart. So you have to have a trucker's mentality, whatever that means. I'm not even sure what that is. So big delivery systems that are stiff, and you have obstacles. Okay, nothing against the TAVR world, but that's pretty easy, right? You're going, I mean, it's not that easy because there's all kinds of vascular issues, but you just have to make one turn and go into the aortic valve. Now, we have to go up, and then we have to go through the tricuspid valve, usually into a huge RVOT, make your way out into the pulmonary valve region. You have to put this really stiff coat hanger wire into the pulmonary artery. There's a chance you can dissect or rupture the pulmonary artery, all kinds of issues that you run into when you get into this game trying to put in big valves and big native RVOTs. And you can run into this problem, and this is why, frankly, I've stopped using the SAPIEN XT. So this was one of the first cases I did with the SAPIEN XT, and you can tell already what the problem is here, right? We had to make an RA loop here to get this to go through the tricuspid valve, get up into this location. We've pre-stented here. And as the balloon went up, I started noticing, gosh, this is stiff. This isn't going up easily. But I was already halfway up. What am I going to do? So deployed the valve and then said, okay, let's now, great, balloon's up, valve's deployed. Let's take the balloon down. Up, balloon isn't coming down, balloon isn't coming down, balloon isn't coming down. 45 seconds, the balloon would not come down. Why? Because all of the torquing and the twisting that we had to do to get this system to go through the tricuspid valve up into the pulmonary valve location had essentially kinked the balloon shaft on this delivery system. This was designed for TAVRs. It's designed to make one turn, not to be torqued a bunch, and we had torqued the hell out of it. So the only way I could actually get this valve out, or this balloon out, was to actually just eventually pull hard enough and get the balloon out. Thankfully, the valve didn't come out. The patient was fine. The tricuspid valve wasn't damaged, but certainly my underwear was. And anyway, thereafter we moved away from this system and actually started using the nucleus balloon to deploy the XT for a while, and then thereafter moved to the S3. This is important. The size of your RV and the relationship of the tricuspid valve to where you're going to end up putting the pulmonic valve is really key. This is a much more difficult implant than this. This is a much straighter shot. So if I see this, I go, oh, great, this is going to go up easily. If I see this, I go, uh-oh, we got a problem. And this is actually, sorry, this is no longer in review. It was published a few months ago, the SAPIEN valve experience, a multi-center experience. But you really, this is where it becomes much more difficult. Be prepared to do an RA loop, a lot of pushing and pulling and such. Pre-stenting, do you need to pre-stent? I don't think so in the majority of cases. This is an example of a patient with native pulmonary stenosis and regurgitation, an older lady. You go in, you balloon size. And once you look at the balloon size and you go, oh, I got a waist there, okay, great. And then you go right at that waist and you put in your SAPIEN 3 and voila, looks great, no problems. And most of the time that's exactly how it goes. But sometimes it comes at a price. So here's a case where we did the pulmonary valve implant and we were so happy and proud of ourselves and it was a really difficult implant. But the patient wasn't doing so well. The anesthesiologist said, you know, something's wrong here. The patient's desatting more, et cetera. So we went up and we looked with ice at the valve. The valve looked great. And then said, let's take a look at the tricuspid valve. Uh-oh, what did we do? Well, what we did was we basically ripped the tricuspid valve. And so this is completely flail now. This septal leaflet of the tricuspid valve and severe tricuspid regurgitation. So this is a potential complication of this procedure. It's not a very common complication. It rarely happens with the Melody valve, but with the SAPIEN valve platform, it can happen because that platform can get disarticulated within the RVOT, and then you can catch tricuspid valve cords. So, you know, you're flying a plane through power lines here, and you have to be very careful. pulling balloons out, pushing them through, not to destroy the tricuspid valve while you're doing it. How about hybrid procedures? So this is a boy that is 10 years old, and I did this case in Bangkok with the surgeons there, and this kid basically had RV dysfunction. They thought the patient was relatively high risk for surgery and cardiopulmonary bypass, so they wanted to do this in a hybrid manner. And the child was relatively small, big RV. So we went in, did some injections here, showed this huge native RVOT with a lot of PR. Where are you going to put the valve here? Very difficult procedure. You do balloon sizing here, and this is with a big balloon. And, you know, the balloon's moving all over the place. I'm unconvinced that there's any waste whatsoever. And if there is one, it's about 31 millimeters in a low-pressure system with a low-pressure balloon. So we kind of got creative with this one in that we took the tricuspid annuloplasty ring, and this is an Edwards physio band, which has this sort of 3D shape to it, and decided to put that in the, around the pulmonary artery as a band. So what we're doing here is we're basically putting in the landing zone. Surgeon does a sternotomy, but not on pump, and then puts that around the main PA. And this is what it looks like. Great, great, okay. And then we go in, do an angio, there it is. Okay, great. Put the balloon back up and looking for coronary and aortic compression here. Small amount of aortic compression, no coronary compression. So we're happy with that. And now we go in through a subxiphoid approach directly into the RV. And with the heart beating, no bypass, and line up the valve, and then we put the valve in. And after the valve goes in, we have really no regurgitation, maybe slight amount there. But we're still a little bit concerned here because did we compress the aorta? Look at how huge that valve is in this little boy's heart, right? And so the aorta looks okay, but where's the left coronary? We were seeing the left coronary really well beforehand, right? And now I can barely see it. Where is it? So I was very concerned that we had compressed the left main here, which has a very intimate relationship to the main pulmonary artery. But luckily, we had not done that, and maybe a slight amount of compression, but not much at all, and the child did fine. So that's an example of a hybrid kind of approach in a child. Aortic compression is a big deal. I mean, this is my work right here, okay? No good. Sorry, I'm basically coming up here and showing a bunch of my complications, but I'm just making Huie look good. But, you know, this is, you do not want to leave this valve in this patient, right? Why? Because, yeah, you hadn't torn the aorta yet. There's no fistula yet, but, you know, it's going to happen. So, no, we sent the patient to surgery. This is where I think rotational angiography is really good with balloon testing. So here we go up with a balloon, inflate the balloon, and look at the aorta with an aortogram, and you can see the compression of the aorta here, how compressed that sinus is. Probably best leave this alone. So we published our experience with aortic compression here and found out that the majority of patients who have aortic compression had native RVOTs. That makes sense. Most of them had tetralogy of Fallot, and the minority actually had conduits. Oh, here, I'll go back. Go for it. And the 14 patients that had aortic compression, only one of them had a conduit. All the rest of them had transannular patches. So it helps us identify, again, the higher risk population for aortic compression. Let's talk a little bit about some of the newer kinds of devices out there for native RVOTs, and I'll end with these devices and a brief review of what we're doing there. So this is the Harmony valve from Medtronic, which is a valve currently in trial, and we're trialing it now at our institution as well as a number of others. What's the difference between this valve and the other valves? Well, this is a nitinol platform, so it's a self-expanding platform, and you can tell by the shape here, it's meant to reduce the size of the RVOT. So all of these, this one, the one from Edwards, and the one that's made in China are all the same kind of idea, which is a reduction in the size of the right ventricular outflow tract. It flares up top, flares on the bottom, and the center is a little bit smaller, and that's where either the valve is already placed or you put a valve in there. The amount of imaging analysis is absolutely exhaustive. And honestly, it's not going to work in the real world. For every patient that I want to include in this trial, I literally have to spend about 2.5 hours on a Cyrix, reconstructing the MRI or the CT, doing all these perimeter measurements, and it's frankly unrealistic. But what the company does for you is they also will basically take these images and will digitally place the valve in the location that you think you're going to put it in. So this is an example of a valve you should not place. Why? There is basically no apposition up top here. The main PA is way too large. This is a more favorable anatomy for placement of the harmony valve. And then they give you these plots that let you know about the interaction of the valve with the RVOT and minimal interference, maximal interference, et cetera. So you can know which patients to go after with this. This is an example of a harmony valve that we put in not that long ago. So there you go, big native RVOT, a lot of PR. And then we put the valve in, and the valve was actually supposed to go all the way up here because you start by unsheathing this in the LPA and then deploy it right up here. But, you know, it's going to go where it wants to go because after we deployed it, it dropped about 2.5 centimeters into the RVOT, but it's long enough where it didn't bounce all the way into the RV. But you can see here you have some perivalve leak. And then this patient now had lots of PVCs. And so, you know, that was one of the problems. But over time on a beta blocker, he was fine. And we've been able to take him off the beta blocker in the last few months. This is by ICE. I use ICE a lot in the cath lab now for pulmonary valve indications. I frankly think intracardiac echo is really underutilized in cardiology. We just use it to look at the atrial septum, the closed PFOs or ASDs, or for EP to do transeptals. I think there's so much more potential to intracardiac echo, and it is the best way to look at the pulmonic valve. Forget TEE, forget transthoracic echo. If you want to know if you have pulmonary valve endocarditis, put an ICE catheter up, flip it up, look directly at the pulmonary valve. Best view you can possibly get. So that's what we did here. This is severe PR at baseline. See how pulsatile that RVOT is. And then this is after placement of the harmony valve. Looks great. But I would have wanted the valve up here, but it's going to take its position. This is the Altera adaptive pre-stent. So Edwards came up with a pretty brilliant solution. Instead of actually making a valve for the native RVOT, they said, nah, you know what, our SAPIEN 3 valve is pretty good. We're just going to have you use that, but instead we're going to design a stent that is going to reduce the size of the RVOT. So we're going to make a landing zone for you. And we're starting this in clinical trials now at my institution, but a lot of these videos are from my colleague Evan Zahn at Cedars, who's the PI on this particular trial. And this is a very nice idea. Why? Because you've got basically, this thing flares out to 47 millimeters distally, 47 millimeters proximally, is almost 5 centimeters in length, and then has a central waist of 27 millimeters. Nitinol frame, open cell PA design, so even if this is across the branch PAs, no big deal. And then you go in and you implant the SAPIEN 3 inside of that. And I'll skip past this video. They want the same interference plots done. So this would be, here, let me show you. This would be a more favorable case, whereas this is not a very good case, right? You don't have enough interference down here, or up here for that matter. Here is an example of a case that Evan did recently. Same kind of idea as the harmony valve, and really the same kind of deployment technique. Sorry, this is frozen. Oh, no. All right, let me close it and restart it maybe. Oh, no, there we go. Oh, now I've deployed. All right, let me go back a little bit. All right, well, let's just play here. So this is after the Altera has been deployed, and you can see that the Altera sits there. It's reduced the size of the RVOT, and the SAPIEN valve sits inside of it. So from a regulatory standpoint, as far as getting this through the FDA, it's going to be a lot easier, right? Because they don't need to get now a bunch of valves through the FDA. It's basically stents. So pretty brilliant. This is the deployment. I just want to show you how that's done. So it's in the LPA that you start, and then you unsheath the first row, and then unsheath the rest of it right in here. And then it basically sits in place because of the radial force. This is ice after the deployment of the valve, working beautifully. This is the venous P-valve system, which is made in China and is in clinical trials in Asia and in Europe. I had the pleasure during one of those trips to Asia where we were implanting the SAPIEN valves to actually also go and do some work with one of the investigators that was implanting the venous P valve. Same kind of concept, but instead of making one size like the Harmony valve, maybe two sizes, these guys have made like 13 sizes. So, you know, but again, how's that going to get through the FDA here? I don't know, but in China, it doesn't appear to be a problem. And they've simplified it as well. And this is, you know, instead of doing all those perimeter plots and interference plots, they basically just said, okay, just measure diameters and then pick the valve that you want and put it in based on diameters. So they're not asking us to relearn something. They're not asking us to become radiologists. Really, they have a much more real-world approach to the way these valves are going to be implanted. And you can see they're quite successful with that implant. And the early data from this valve are excellent. So I think this concept is going to really take off. So conclusions. Transcatheter pulmonary valve replacement is feasible and it's effective. It's here, it's now. Infective endocarditis is an ongoing concern. The Melody valve is too small for many adults with native RVOTs, less than or equal to 24 millimeters. The SAPIEN XT and the SAPIEN 3 offer larger sizes and sturdier stent platforms and possibly a lower risk of infective endocarditis, but the delivery systems are more technically challenging. So be wary of injuring the tricuspid valve, as I showed in that one case. The aortic and coronary compression issue is real, so it should be assessed. And are there ways to tell before you get to the cath lab if you're going to have aortic compression? I don't think so. Coronary compression, maybe. Distance, where we're presenting some of our data at Sky about this, but if your coronary artery is more than 3 millimeters away from your landing zone, and if you do not have a conduit that's up against the sternum, the likelihood that you're going to get coronary compression is actually quite low. So I think in that population, we can be more aggressive, balloon dilating up these conduits. The next generation of our VOT reducers, and I showed you 3 of them, the Harmony, the Altera, and the venous P valve, are currently in clinical trials, and this is what we're going to see coming into clinical practice in the next few years. And if we go back to that early chart that I showed you, the 77% of patients versus 26% of patients that, or 23 and 77, those native RVOT patients, the vast majority we will be able to do using transcatheter work. So thank you very much, and I'll take any questions, and I'm sorry if I went a little bit over.
So actually, Steve, you already have a question. All right. Thank you very much, Jamil. We'll go ahead and start with Steve with a question.
Thanks. That was a fantastic talk, very interesting, and a field that I personally know almost nothing about, but now I do know a little bit. In the scenario when the main PA is really unfavorable, or particularly if you're worried about aortic compression, what's the feasibility of just putting a transcatheter valve in each of the left and right PAs?
Brilliant. Quite feasible. Done it a number of times. Expensive solution to the problem, but yeah, very doable. Very doable. Question is, do you get the same kind of long-term hemodynamic result if you valve the branch PAs as if you valve the main PA? The early data suggests that you do, but there's just not enough cases out there yet to, make any sort of definitive conclusion.
Let me ask you from a clinician standpoint. I mean, what is your feeling about the patient's symptoms, or they're clinically, how do they feel after branch PA revalving? Has that been good, bad? Same?
No, it's been honestly, in the maybe 5 or 6 cases that I have done with branch PAs, I have not noticed any difference in how people feel compared to if I had just done a native RVOT, valve implantation. So, Yeah, but again, the numbers are too small for me to make any definitive conclusions. Good idea, though.
Thank you. That was a fascinating talk. I agree with all the previous comments. My question is, do we know anything about the durability of these valves compared to surgical valves?
Great question. So I showed you some of that data on the Melody valve. And if it doesn't fracture and if it doesn't get infected, then it looks like it does pretty well. We don't know about the durability of the Sapien valves, though. That is one of the most difficult questions to answer when I'm speaking to patients and families, because they ask me, they go, well, how does this compare to the surgical valve, 15, 20 years later? And I say, I have no idea, and there's no way I can tell you that. My suspicion is that the large diameter Sapien valves in the native RVOTs are going to perform as well, if not better, than surgical valves. Because if I can get that valve up to 30, 31 millimeters in diameter, there's no central leak to it, the risk that that valve is going to get stenosed in the long run is almost nil. So we'll probably be dealing with valve regurgitation long term. But in the last 4 years or so that I've been using the Sapien 3 valve, I have not had to replace any of them. And that's only 4 years, but, we'll see. We'll see.
Enjoyed very much your talk.
Thank you, sir.
Are we intervening, with your vast experience, are we intervening too late on these patients? I mean, there are some guidelines there, but the question is, most of the time, the RV has failed, so quite a bit of diastolic dysfunction. And I think with those kind of experiences and non-surgical intervention nowadays, it is probably time to take a look at these outcomes.
So, this comes up all the time. There's one school of thought, Lee Benson and the group in Toronto, that basically say that anybody with severe PR, regardless of the size of the RV, symptoms, et cetera, they're going to put a pulmonary valve into that patient. They do not leave anybody with volume overload. And the logic that Lee uses, and I had to debate him a couple of years ago at PICS about this, logic is, would you leave a large secundum ASD untreated, right? You wouldn't. You would close it because you know that that patient's going to be volume overloaded. So that's the logic behind that. The problem is the clinical evidence for us actually altering long-term outcomes with those early interventions is not there. And there's been numerous studies that have looked at this, that have shown that, we can't show any difference in long-term clinical outcomes if we intervene early on in a younger child than if we wait until the RV is a bit larger and the patient maybe has symptoms. So what have I done? What I do is I rigorously look for reasons to intervene. So I do cardiopulmonary exercise testing in the patient. If the patient doesn't do as well as they should, that's one reason to intervene. We combine it with echo. We look at RV augmentation with exercise. If we intervene. If there's progressive tricuspid regurgitation, we intervene to save the tricuspid valve from developing progressive annular dilation and regurgitation. So I'm pretty aggressive about intervening early, but I'm also somewhat hesitant to really push that aggressively because of the complications of these procedures, endocarditis, tricuspid valve injury. It's not, it's a little bit difficult to tell everyone to intervene aggressively, and then you start running into major complications in these patients when we didn't know from the get-go that we were actually altering long-term outcomes.
Maybe his aggressive approach would be a control for other people's. that could be. Maybe a crazy question from a non-interventional to an interventional person. You told us about the twists and turns that you have to go to deploy this, and the tugging and the pulling. Do you ever go from an IJ with one loop as opposed to two loops?
Yep. Yeah, we often will go from the IJ if we're having trouble going from the femoral vein. The problem with going from the IJ is, especially with a 22 French system, it's a pretty large system putting it through someone's IJ, and they end up with a nice big scar there. So that's part of it, and we are in Los Angeles, so that's kind of an issue where I come from. So that's one part of it, and the other part of it, honestly, is the ergonomics in the cath lab of trying to put these large systems in through the jugular vein, especially if you need biplane and the patient's intubated as well. And there's just not much room back there. So if I'm going from the IJ, I essentially have to use single plane because it's impossible to do it with biplane. There's just not enough room. Some people have advocated flipping the patient on the table so that they're upside down on the table, or head down on the table. That may be a better way to do it. But yeah, the IJ is certainly a way we can go.
Well, great. Thanks, Jamil. So just a quick reminder. So at noon, we have the Fellows Lunch with Dr. Aboulhosn, and you guys can ask some more questions then. Thank you again.
It's great to see you, dude. It's going to look great. You don't look any older. That's amazing. I sent Manisha a picture of you. I was telling her you were here. I'm sorry, I have to run. I have a ventilation on the table.
So at one point, you were my fellow, and he was the attendee. Not that you remember him.
Hello, my name is Alan Lumsden. I'm the chairman of the Department of Cardiovascular Surgery here at Houston Methodist Hospital.
And I'm Zvonimir Krazier, current president of the International Society of Endovascular Specialists. We are excited to invite you to join us for our first annual IS-EVS Symposium. This premier conference will take place at the Houston Methodist Research Institute in the Texas Medical Center.
This is a 2.5-day conference, and it will offer didactic lectures from well-renowned cardiovascular interventionalists. It will also feature intensive hands-on workshops designed to teach interventionalists a variety of techniques. We plan to offer 3 tracks, one for the novice, or the new young surgeon or young interventionalist, an intermediate track, and an advanced track. That means you can hone your skills at an individualized level. By the end of the conference, attendees should be ready to apply these techniques and improve their clinical practice.
We hope you will join us, and we look forward to seeing you in September.
Hello, I'm William Zogby, Chair of the Department of Cardiology at Houston Methodist DeBakey and Heart and Vascular Center. I'd like to invite you to join us in Houston, Texas for the 9th annual multimodality cardiovascular imaging for the clinician. This special event will be held on February 22nd to 24th, 2019 at the Houston Methodist Research Institute in the Texas Medical Center. Cardiovascular imaging plays a vital role in the management of cardiovascular patients. Knowledge of the various imaging modalities is indeed critical in understanding their advantages, limitations, and appropriate utilization. This is in patients with ischemic heart disease, heart failure, cardiomyopathy, valvular heart disease, as well as aortic disease. In addition to didactic lectures by world experts from this country and abroad, this 2.5-day symposium offers small group tutorials, each imaging modality, demonstrating heart anatomy to better visualize and understand cardiac and valvular structures, along with other imaging modalities. The course is designed for physicians, mid-levels, nurses, trainees specializing in cardiovascular disease. We also encourage nurses, sonographers, imaging technologists, and echocardiographers, cardiac CT, and MRI specialists to attend. I hope you will join us for this conference and look forward to seeing you in Houston in February. For more details, please visit our website.